from primary achalasia. Achalasia continued. Chagas disease causes a secondary achalasia that is indistinguishable radiographically from primary achalasia. Complications of chronic achalasia include esophageal cancer, which has a lag period of at least 20 years, and candidal infection from stasis. The classic imaging appearance of achalasia is a massively dilated esophagus with a bird's beak stricture near the gastroesophageal junction. Treatment options include physical disruption of the lower esophageal sphincter by pneumatic dilatation, surgical myotomy, Heller myotomy, or peroral endoscopic myotomy, POEM, and pharmacologic interventions such as botulinum toxin injection. Pseudochelasia is caused by an obstructing gastroesophageal junction cancer mimicking primary achalasia. These can be differentiated on fluoroscopy because in achalasia there is eventual transient relaxation of the narrowing when the patient stands, but the fixed obstruction of pseudochelasia will not relax with standing. Scleroderma. Scleroderma is a systemic disease involving excess collagen deposition in multiple tissues. The esophagus is involved in 80% of patients with scleroderma, producing lack of peristalsis of the distal two-thirds of the esophagus due to smooth muscle atrophy and fibrosis, which leads to marked esophageal dilation. Secondary candidiasis or aspiration pneumonia can result from prolonged esophageal stasis. The esophageal dilation is often apparent before the typical skin changes of scleroderma become evident. Diffuse esophageal spasm. Diffuse esophageal spasm is a clinical syndrome of chest pain or dysphagia caused by repetitive, non-propulsive esophageal contractions. The non-propulsive contractions have a characteristic appearance on barium swallow leading to the descriptive name of corkscrew esophagus. Single contrast esophagram demonstrates delayed passage of barium through the esophagus, with multiple tertiary contractions in a corkscrew configuration, and subsequent esophageal reflux not shown. Esophageal diverticula. Types of diverticula. Traction diverticulum, lymph nodes. Pulsion diverticulum. Pulsion diverticula are caused by increased esophageal pressure. They usually occur near the GE junction, and comprise nearly all diverticula seen in the United States. Traction diverticula are caused by external traction by mediastinal inflammation adhering to the esophagus with associated lymphadenopathy, usually in the mid-esophagus. They occurred in the past when TB and other infections were more prevalent and are rarely seen today. Zenker diverticulum. Lateral and right anterior oblique barium esophagram images demonstrate contrast filling a blind-ending pouch, arrows arising posteriorly from the pharyngosophageal junction at level of C5. In keeping with a Zenker diverticulum, Zenker diverticulum is caused by failure of the cricopharyngeus muscle to relax, leading to elevated hypopharyngeal pressure and resultant outpouching. Symptoms of a Zenker diverticulum include halitosis, aspiration, and regurgitation of undigested food. A Zenker diverticulum is located in the hypopharynx, just above the upper esophageal sphincter, cricopharyngeus muscle, and is posteriorly protruding. The cricopharyngeus muscle is usually hypertrophied. A Zenker diverticulum is best seen on a lateral view. Killian-Jamieson (KJ) diverticulum. Frontal view from a barium esophagram shows a 3 cm Killian-Jamieson diverticulum on the left arrow. A Killian-Jamieson (KJ) diverticulum is located in the proximal cervical esophagus, at the Killian-Jamieson space, which is an area of weakness below the attachment of the cricopharyngeus muscle. A KJ diverticulum protrudes anterolaterally, best seen on the AP view, and is more often bilateral. KJ diverticula are less commonly seen than a Zenker's diverticulum. Both are false diverticula. In contrast to a true diverticulum, a false diverticulum does not involve the muscular or adventitial layers. Pseudodiverticulosis. Pseudodiverticulosis is the imaging finding of multiple tiny outpouchings into the esophageal lumen caused by dilated submucosal glands from chronic reflux esophagitis. These submucosal glands are analogous to the Rokitansky-Aschoff sinuses of the gallbladder. Pseudodiverticulosis is often associated with a smooth stricture in the mid-upper esophagus, which may cause symptoms. Candida is frequently cultured, but infection is not believed to be the causal factor. Miscellaneous esophageal disorders. Feline esophagus. Feline esophagus is thought to be a normal variant, characterized by multiple thin transverse esophageal folds. There is a controversial association with esophagitis, where the incidence of esophagitis may be increased in the presence of feline esophagus. Compared to eosinophilic esophagitis, the circumferential folds in feline esophagus are thinner. Feline esophagus. Spot image from double contrast esophagram shows characteristic multiple transverse folds in the lower esophagus. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Aberrant right subclavian artery. Aberrant right subclavian artery. Oblique single contrast barium esophagram, left image demonstrates a smooth posterior indentation of the proximal thoracic esophagus, arrow. Aortogram in the same patient, right image demonstrates the aberrant right subclavian artery, ARS, asterisk at origin crossing midline before heading towards the right arm. This patient has an additional aortic branching anomaly, with the left vertebral artery, LV, arising directly from the aorta. The right vertebral artery, RV, arising from the aberrant right subclavian, is hypoplastic. The right and left common carotid arteries, RCC and LCC, and left subclavian, LS, are normal. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Aberrant right subclavian artery, with a normal left arch, is seen in approximately 1% of patients and is almost always asymptomatic. The aberrant right subclavian artery travels posterior to the esophagus, where it may rarely produce dysphagia. On an upper GI study, the resultant posterior esophageal indentation is always smooth. Rs. Asterisk. RV. RCC. LCC. LS. Stomach. Anatomy. Cardia. GE junction greater curvature lesser curvature pylorus. Duodenal bulb. Hiatal hernias. Hiatal hernias. A hiatal hernia is present when abdominal contents herniate up through the esophageal hiatus into the posterior mediastinum and gastric folds are seen above the diaphragm. There are 4 types of hiatal hernias, which are managed differently. The Society of American Gastrointestinal and Endoscopic Surgeons (SAGES) 2013 guidelines do not recommend surgery for type 1 hernia in the absence of reflux disease. However, all symptomatic paraesophageal hiatal hernias, type CIV, should be repaired, particularly with acute obstructive symptoms or volvulus. Type 1. Sliding hiatal hernia, most common. A sliding hiatal hernia is present when the gastroesophageal junction, GEJ, slides up into the posterior mediastinum and gastric folds are seen above the diaphragm. Type 2. Paraesophageal with GEJ in normal position, least common. A type 2 hiatal hernia is herniation of the gastric fundus, with a normally positioned gauge below diaphragm. Type 3. Paraesophageal with GEJ above the diaphragm, second most common. In a type 2 hiatal hernia, both the GEJ and fundus body of the stomach protrude into the lower mediastinum. Type 4, associated with herniation of other organs above the diaphragm. A type 4 hiatal hernia is displacement of the stomach and other organs, spleen, pancreas, small bowel, colon, above the diaphragm. Hiatal hernias, continued. Normal. GE junction type I type 2. Type 3 Type 4. Illustration demonstrates the 4 types of hiatal hernias. Paraesophageal hernia. Frontal and oblique single contrast barium upper GI study shows intrathoracic herniation of the gastric fundus, yellow arrows, consistent with a recurrent paraesophageal hernia in this patient with prior history of hernia repair. The GE junction, red arrow, remains below the diaphragm, consistent with a type 2 hiatal hernia. Gastric volvulus. Gastric volvulus occurs when the stomach twists on its mesentery by at least 180 degrees and results in bowel obstruction or ischemia. The stomach may be partly or entirely above the diaphragm. If the stomach is twisted but without obstruction or ischemia, it is referred to as gastric rotation. Organoaxial rotation, volvulus, is when the stomach rotates on its long axis. Mesenteroaxial rotation, volvulus, is when the stomach rotates on its short axis. Most commonly occurs in the satiety of a paraesophageal hernia or trauma. Gastric volvulus. Axial, left image, and coronal, right image. Oral contrast only CT shows mesenteroaxial gastric volvulus with the distal stomach, yellow arrows, located in the chest through a large hiatal hernia. The gastroduodenal junction, red arrow, appears to be cranial to the gastroesophageal junction, blue arrow. Enteric contrast is pooled in the proximal stomach with reflux into the esophagus. No contrast is seen distal to the stomach. Thick-end gastric folds. Thickened gastric folds are most commonly due to inflammatory gastritis, which characteristically produces smooth fold thickening. Nodular fold thickening is suggestive of neoplasm, either gastric lymphoma or submucosal carcinoma, which may be primary gastric or metastatic. Contrast-filling thickened gastric folds, arrows, on a double contrast barium study, thought to represent gastritis in this patient. Helicobacter pylori gastritis. Helicobacter pylori is a major cause of gastritis, gastric ulcers, and duodenal ulcers. Zollinger-Ellison Z syndrome. Zollinger-Ellison Z is gastrin overproduction from a gastrinoma, which is a neuroendocrine tumor located in the duodenum or pancreas that has a 50% rate of malignancy. Z features elevated gastrin level and a paradoxical increase in gastrin after secretin administration. 25% of patients with gastrinoma